Hello, again, welcome to week 4 lecture, Skin Conditions. I am wearing my 49ers hat because they actually won today. Tough game, but they did it, so we are wearing the 49ers hat in honor of the win today. Anyways, to start off with skin conditions, what our learning objectives are, we're going to compare clinical manifestations and pathophysiology, clinical treatments, and nursing management of common skin conditions in pediatric clients, compare and contrast communicable diseases, disease rashes and allergic reaction rashes, discuss nursing care for treatment and preventing of pediatric skin conditions. So the disease processes we're going to be covering in this lecture include diaper dermatitis, atopic dermatitis, eczema, impetigo, scabies, and pediculosis capitis. Very exciting. So diaper dermatitis, 35% of all young children, infants in diapers will have a diaper rash. What causes the diaper rash? It is caused by prolonged and repetitive contact with an irritant. In this case, it's going to be urine or feces. This can also, you can also use this as if they have a G-tube or a ostomy, if you have feces or a urine diversion, know that this is very irritating to the skin. So anything that stays on the skin can irritate the skin and cause some kind of skin condition. So it's important if they're not normally, if they don't void normally, so if they're voiding through a device, urinary diversion device, or if they're if they have bowel movements through an ostomy, that we make sure that we take care of the skin that is surrounding those different types of devices or diversionary devices. So diaper dermatitis is usually found primarily in the convex surfaces. They're usually found in the folds or on the bottom areas. Can have a variety of configurations depending on how severe the case of diaper dermatitis is. And they occur in areas that are in the most contact with the diaper. So this is a diaper rash that is caused by yeast. So there's a different type of look when you have a rash that is caused by yeast. It's raised rash, and you can see the little white spots in there. And that is indicative of the yeast. It will often be included in the skin folds and all around the diaper. It is not. It's not something that can be treated with normal diaper creams. This needs a nystatin cream or a fungal cream to help it go away. So prevention and treatment of diaper dermatitis change frequently. Usually standard is we should be checking the diaper at least every 2 hours to see if it's wet, or when we go in there and we notice that it is wet, we should change the diaper. Make sure that we clean and take all of the feces and urine off of that skin when you change the diaper. If it is a very, very bad diaper rash, there are times that we will leave the infant diaperless. We'll just put them on chucks and let the air get to that area, and that actually helps to heal. So open to air will help the diaper rash heal, but you have to be aware that they're on a chucks as well, and so you need to change that chucks. And it has to be an infant that will move off of the chucks, and so that you're not changing the entire bed every time that you go into the room, and you're checking it on a regular basis, more often than every 2 hours probably. Another thing that we use is to put oxygen and take the tubing from the ambu bag or some other tubing, and if you just have oxygen on that area that is irritated, it actually helps to heal as well. And those are really, really severe cases. In the really severe cases, diaper dermatitis, you're going to see a skin excoriation, you're going to see some possible bleeding, just really, really sensitive skin. Those babies are going to be very, very irritable, especially every time they pee or they poop. They're going to be very irritable because it's going to get on their skin and it's going to make them, it's going to be painful for them. Things that you can use are barrier creams. So when you see a diaper rash coming on or irritation coming on, then automatically go ahead and use diaper cream. Those are available to you in the storage areas. put some barrier cream on there. It should just prevent moisture barrier cream that prevents the moisture from hitting the skin. In really bad cases, you can put some hydrocortisone ointment on there, but you cannot use hydrocortisone for yeast infections because the hydrocortisone will make the yeast infections worse. Zinc ointment is also something you can put on. There are some, for the really bad cases, there are some prescription creams that they might prescribe for that patient. So be aware of what your wound care, your skin care regimen looks like before you do anything for them. Also, you can use nystatin powder. There is a little powder of nystatin that you can kind of shake in on top of the skin or in the diaper that will help and when they have a yeast infection. Atopic dermatitis. So we're going to talk about what that is. It is a category of dermatologic diseases. It can affect anyone from infants to adults. They do come in 3 different forms, and each form has a slightly different presentation than the other forms. So we have infantile eczema, childhood eczema, and adolescent or adult eczema. Infantile eczema begins between 2 and 6 months of age, and generally it will go away by the time that they're 3 years old. Sometimes not, but generally they will go away. It's usually generalized rash that you will see on the cheeks, on the scalp, on the trunk, exterior surface of all the extremities. They can appear as erythema, vesicles, papules. They could be weeping or oozing or crusting, scaling, just depending on how severe this case is. And lesions can often appear symmetric. So those are things to look for when they have infantile eczema. So when you look at it, this is a very severe case of infantile eczema. They see on the face, the elbows, and the knees, and you see on both sides symmetrically. In this case, again, it is severe. So what you really want to be concerned about is a secondary infection, a secondary bacterial infection. And when you have skin that's broken like that, that is a time when that natural flora can take advantage and can cause secondary infection. So again, childhood eczema, which is different than infantile eczema, you will usually find that in the flexural areas, in the antecubital spaces, the popliteal spaces, the wrists, ankles, and the feet. They are also common symmetrical as well. They can be seen in clusters, small erythematous or flesh-colored papules. They might be scaling or have maybe a little bit of scaling patches. Dry, their characteristic is usually that they're very dry, and they might be hyperpigmented. You might also see keratosis pilaris as part of this childhood eczema. So here is just a little diagram of where you might find them. As you can see, the back of the knees or the popliteal areas on the back, also maybe in the abdomen area or the diaper area, depending on if they're still wearing a diaper. This is an example of atopic dermatitis that has turned into a secondary bacterial infection and has some severe excoriation to it. So you can see those reddened, scaly vesicles. They're very dry and they are very itchy. And so when they itch, you can cause some skin breakdown, continuous skin breakdown. That's when the bacteria can get in there and cause a secondary infection. Adolescent eczema occurs in the face, the side of the neck, the hands and the feet, antecubital areas, popliteal fossa. They can be very similar to childhood manifestations. They can also see the lichenified plaques are also common on adult and adolescent eczema. So for atopic dermatitis, they can also have swollen lymph nodes and increased palmar creases, atopic pleats, tendency towards cold hands, pityriasis alba, facial pallor, which means just their pale face, bluish discoloration underneath their eyes, and increased susceptibility to unusual cutaneous infections. So they might be more susceptible to skin infections that you don't normally see on other people or other patients. Management, so this is important. So our job as nurses is to make sure that we manage the the dermatitis, or so that it doesn't get any worse, and then actually hopefully will get better. So ways that we can do this is to make sure that the skin stays hydrated, and that we can give them a little tepid bath with an emollient application. Might help them when the skin is very inflamed. Relieve their itchings also with some tepid baths, maybe some oatmeal baths, so you can put them in these baths that will help soothe their skin. Cool wet compresses on the areas that are more severe can help the itching. Reducing the inflammation or the flare-ups. We educate the parents to avoid irritants. So it could be soap, the type of clothings like scratchy clothings. We ask the parents to use mild soaps without dyes and perfumes, and that will help with the flare-ups as well. And then we want to prevent and control any infections. So prevent infections by relieving itching, making sure that they, if they're babies, that they can't scratch, we keep their nails nice and short so that if they do scratch, that they can't break the skin. Things that will keep them from making it worse than it already is. So the next one to talk about is impetigo. Impetigo is a bacterial infection. It's an infection with Staphylococcus. This is a very common infection among pediatrics as well. And it is something that you might see in the hospital because the infection is severe enough. These patients will not be eating and drinking a whole lot. So they usually come in dehydrated, or they're in need of nutrition because those impetigo around their mouth, it makes it painful for them to eat. So they stop eating. And so they might come in to get some antibiotics or some hydration, IV hydration, because they aren't eating and drinking very well. So this is a thick honey-colored crust on the, mostly see it on the face, and it spreads peripherally. So it'll start maybe next to the mouth and spread through the cheeks. Have irregular outlines, as you can see in this picture here. It is very itchy, so pruritus is a symptom of impetigo, which is also a problem because you don't want them scratching and spreading this bacterial infection around. We will treat these impetigo infections, and we can remove the crust and also treat with antibacterial ointments. Mupirocin topical ointment is a common treatment for this for impetigo. And in severe cases, we may prescribe IV or oral antibiotics, depending on how well we can treat and control the spread of this. The next one we talk about, we get into some of the more fun diseases, and this is scabies. Scabies is an infection which is caused by the scabies mite that you can see a microscopic picture right there. You can also see a picture of what scabies infection looks like. You can see those areas where it's red, and that you might see the white spots. That's where they burrowed and laid the eggs. So mites will burrow in the stratum corneum of the skin and deposit eggs and feces. So what you will see, you'll see those lesions like you just saw on that previous picture. Minute grayish brown thread, like where the mites are burrowed. It's very itchy. The black dot at the end of the burrow is the mite. So if you look in the previous picture, let's go back. I can't go back, unfortunately. If you go back to the previous picture, if you look at those examples of the scabies, you can see where the black dot, and that's where the mite has been burrowing. Distribution, where do they usually find it? Interdigitally, so enter in between the digits, axillary, cubital, popliteal, inguinal. If you look at figure 50.6 in your book, you can see more where that distribution is going to be. Children older than 2 years of age, they usually see it primarily on their hands and their wrists. And younger than 2 years of age, they're going to see it mostly on their feet and their ankles. So age does have a little bit of a factor in where you're going to find these scabies, these locations where the mites have burrowed. So manifestations, what are their symptoms going to look like? Again, you're going to see a macular papular lesion between the fingers, under their arms, behind their knees, in their inguinal area. If you really look really close, you can see the burrowing scabies. And again, it's very, very itchy, so they're going to be scratching. Treatment for scabies, okay, you can see here, maybe in these little pictures here where the mites are, the brown the brown little dots. But treatment for scabies, permethrin 5% cream, or oral ivermectin are antiparasitic medications that can treat this disease. So permethrin 5% topically, and then in really severe cases, we'll give them the oral ivermectin. Anyone that's been in close contact with someone with scabies needs to get treated. So if you happen to have a patient that has scabies and you don't know they have scabies until after you've been working with them and you haven't been using your PPE, I would recommend that you get treated for scabies and to be aware and to watch for an infection. Cream must be applied to all skin and left on for approximately 8 to 12 hours. So once you apply this cream, do not take it off and leave it on for 8 to 12 hours for it to take effect. Another little bug that can cause infections in pediatrics is pediculosis capitis, and these aren't exactly infections that you would see as primary infections in the hospital, but you might see patients come in and they have this as well as a whatever disease process they're actually being admitted for. But the pediculosis capitis is also known as head lice. It's infection of the scalp by parasites, and as you can see, there's a really nice picture of the head louse in here. And their eggs that they lay are called nits, and those little nits are little white dots you see on the shafts of the hair. It's most common you find in school-age children, but you can find it in any age up to adolescence. There's no real age restriction on head lice. Anyone can get it. It can be an embarrassment and concern for the family and the community. So definitely treat these patients and respect them, and just let them know that you're there to help them, and no judgment when we're treating these patients. So again, here's the louse. It's a blood-sucking organism. So what it does is it will on the scalp, take bites out of the scalp or the blood. They can live up to 48 hours away from human contact, which is important to know when you're educating the parents about how to treat and prevent these lice infections. They can live on a host for about a month. They will lay their eggs close to the scalp on the shafts of the hair, and the eggs will hatch in 7 to 10 days, which again, it's something that you should be aware of when you're educating the parents and the family members about preventing or how to treat the lice. We usually tell them to do a nix treatment right after they find out that they have any lice infection, and then 7 to 10 days after that lice infection to kill any other lice that have hatched during that time, because the nix doesn't always kill all the eggs, but so that's why you have to do a retreatment after 7 to 10 days. Manifestations, it's going to be itchy every time. You're probably thinking about this, you start itching your hair, but it's very itchy. So if you see someone itching their hair a lot, you might want to take a closer look to see if they have any indications of lice or of the nits in their hair or of the eggs in their hair that will indicate that they do have lice. They're usually found at the base of the neck, behind the ears. So you're going to maybe lift their hair and look at the base of their neck. That's where you're going to most likely find the nits and the lice. So they are attached to the hair shaft, so you have to really go in there a little bit and look to make sure that you don't see, or you do see those little eggs that the louse lays. Treatment, over-the-counter treatment, so you can get Nix, which is a 1% cream rinse of permethrin. Same thing you would treat for scabies, but in this case you're treating the hair, not the skin. You can also get Rid, which is another treatment. It's permethrin plus piperonyl butoxide, so just another chemical that is meant to help kill, I believe, the eggs. And there's also a prescription medication that you can get in really severe cases or cases that seem to recur, and that's a 0.5% malathion. So in order to treat them in that treatment, you also, not only will you wash their hair with this special shampoo, but you're going to take a special comb and comb their hair so that you can take the nits and the fleas. You can capture them in the comb. They're really fine comb with very little spaces in between, and these can capture the fleas and the nits and take those out. So hopefully the parents can help you with this. If they're there, they will help with the washing of the hair and removal of nits. You will also educate the parents and the families that they will need to machine wash all washable clothing, towels, linens, etc. in very hot water and dry on high heat for at least 20 minutes. This hopefully will kill all the nits and the lice that you can find on these clothes, since it can live for up to 48 hours after on objects. We want to make sure that we kill them all. Thoroughly vacuum your carpets, car seats, pillows, stuffed animals, rugs, mattresses, and upholstered furniture. And I would do it very often for the first 14 days to make sure that you don't have any leftover lice that's out there that can cause a reinfection. If there are things that are not washable, stuffed animals, like pillows without the pillowcases, those types of things you can place in a plastic bag for 14 days, and that should help kill the lice, because they can only live for about 48 hours, but they can live for 7 to 10 days on the hair. We just say 14 days to be safe, that we get rid of all of the lice. So this is the education that you're going to give to the parents as when they're getting discharged, if their child has lice. So again, nursing management will include a lot of education, identification of the condition. So if you suspect lice, they will be put on contact isolation. So just to know that. Another type of infection is fungal infections of the skin. So we talk about tinea, and depending on the location is what you're going to call is how you diagnose this. So tinea corporis on the skin area, tinea capitis is going to be on the head area, tinea pedis is going to be on the feet. Makes sense. Tinea curis is going to be in that more of the like diaper area or lower abdominal area. So good health and hygiene is very important. If someone does have a tinea infection, that's important to educate them not to share clothing, towels, shoes, etc., so that we don't spread it. Washing hands after handling pets is also very important. The treatment for this infection are antifungals, and these are just a couple examples of antifungals. Itraconazole, miconazole, anything that ends with an azole, A-Z-O-L-E is an antifungal. So any of those types of medications will work, and it could be an over-the-counter cream medication that you can get. So it is transferred person to person, but it also can be transferred by inanimate objects, so as fomites. So make sure that you do know someone that has a infection, that will use proper contact precautions so that we don't spread that infection to other patients or to ourselves. Rickettsia, this is a disease that is transmitted by arthropods, by bites, so spider bites. These are ticks or any little arthropod. They are infectors and reservoirs, so that means that they hold the bacteria, but they also spread it, so they infect and hold it. These are intracellular parasites. You find them most often in tropical warm settings, so not really in California a whole lot you won't see these, but you might see them in Florida or anywhere it's a tropical setting. It's hot and humid. Eruptions caused by Rickettsia, so you can have Rocky Mountain spotted fever. This is a tick is the thing that will infect the person. So if the person's bit by a tick, the tick is carried by wild rodents and dogs. So if you do have a dog and like to go hiking, and this is same thing, kind of same you want for Lyme disease, it's spread by ticks. So you want to make sure that you inspect the dog if you go hiking, inspect your legs if you go hiking through areas that have a lot of ticks, so that you can hopefully find and prevent this infection. You also have epidemic typhus. The epidemic typhus is caused by the body louse or body lice, and it is carried by infected feces into broken skin. So if you have infected species and you have some broken skin, it gets in there, that can cause the epidemic typhus. The endemic typhus, so epidemic and endemic are different. Endemic typhus is caused by rat flies or lice. So it's a flea bite or inhaling the flea excrement, and the rice are the carriers of rat flies and lice that carry this endemic type of typhus. And then the last thing we can talk about is rickettsial pox. So this is caused by a mouse mite bite, and these are carried by house mouses, house mice. So if you have a mouse in your house and they have a mite that bites you, you can get the rickettsial pox. I feel like there is some kind of children's rhyme in there somehow. Anyways, very uncommon in this area, but it's something that you should be aware of. Findings, rickettsial findings, so size and morphology depends. So erythema, ecchymosis, petechiae are there. It could be a primary, secondary lesion. The pattern is usually either bilateral or unilateral, so it could be either one, local or systemic pattern. They can be discrete or clustered, diffuse or confluent, so basically anything what you're looking at. Diagnostic testing, you're going to be doing it by biopsy or scraping. So you're going to scrape that skin, and so you can biopsy it to make sure see what it is. They're going to look at it under a microscope to identify the organism. You might also have some blood work. They might do some autoimmune testing, because of course people with autoimmune diseases are most likely to get this, or they can use a wood light to examine your skin. Let's see. Treatment. So treatment for all types of these rickettsial infections include tetracycline and chloramphenicol. So those are the two things that you can use to treat any of the rickettsial infections, and also supportive care. So here's a question for you guys to answer, and I'm going to leave it to you to try and figure out the answer yourselves. You can always ask what the answer is, but school nurse has identified several students that have pediculosis capitis, so they have lice at school. They were treated with Nix, and the recommended treatment is repeated in 10 days. The nurse wants to educate the parents on how to prevent another outbreak. What is the most appropriate education? And this is one of your select all that apply. So this is one of the practice questions that you can use to, it's something that we have that you'll see on the NCLEX, that you're going to see on ATI, and then you're going to see on all the testing for EDC in all of the semesters. So this semester, third semester, fourth semester, all utilize these types of questions because this is what you're going to see on the NCLEX as well. Let me know what your thoughts are on the answers to this question. I will see you for the midterm. Email me if you need anything or have any questions. Thanks.